All right. So today I am starting out the announcements because I think Aaron has trouble with hypothalamic issues. No, this is about opioid-related hypothalamic issues. And unfortunately, Aaron is unable to say that word. Uh, so we have Ethan Stortz. That's a hard word to say. Stortz. That's tough.
Close enough. Storts is perfect.
Stortz, man, I don't think I've ever met somebody with that last name. And so that's our talk for today. We'll get to that in just a moment. Next slide.
Sorry, Dr. Storch, that we're riding the struggle bus today.
Hey,
It's
that
a
makes
challenge.
multiple. I am as well. Not a problem.
All right, we have some wonderful upcoming sessions, so check them out. I'm really looking forward to Abigail Judge's talk coming up on June 5th. She was referred by a friend of mine that I work with in the Building Bridges Initiative with the BJA, and she came highly recommended, so super excited. And for Dr. Ross Miller's talk on opium as well. I don't think I've ever seen a presentation on opium, so I'm kind of pumped about that too.
Yeah, and he has multiple patients that have shown up taking actual opium. So it should be just tons of fun. Now, Essie Agenta, she is actually was the that's doing the food addiction factor fiction. She actually was the addiction fellow last year. So I ran into her in Dallas and she was excited to do some talks for us. So she's doing a couple. So lots of fun ones. And then pregnancy and marijuana, you're gonna have to tough through it with me coming down the road. So
yep. Also, there's other echoes that are offered if we can go back that are just listed on the bottom of the screen. So check those out as well.
All right, remember there's free CME. Please, if you don't mind, turn on your video because Ethan would love to see your faces. There's nothing worse than chatting to a bunch of black boxes, and we'd love to see your face. And Erin loves to see what people are eating. She's living vicariously through what you're eating. So feel free to turn that on.
We are here for you. If you have any technical assistance needs, our contact info is listed below, so don't hesitate to reach out.
And last but not least, you can go online to the Center for Opioid Resources, all kinds of stuff there, protocols, different things. So check that out if you need that. All right. So with no further ado, we'll get to Dr. Stortz. Man, I see I can't say that. You have trouble with hypothalamic, but he's going to come at us today with the opioid-related hypothalamic issues. And if you want to introduce yourself a little bit, just kind of tell what kind of fun things you do for work. That'd be great.
Yeah, I'd love to. I am Ethan Stortz. I am from Minnesota, but I currently am coming to you from Denver, Colorado, where I'm completing a fellowship in addiction medicine. I'm also a trained endocrinologist. I did that fellowship before this one. And so kind of a mixture of a couple different interests, but, you know, over medical training, there's a couple areas of overlap that I'm super interested in. Some are more clinically relevant than others, other probably more research issue, but I spend maybe a little more time thinking about some of these endocrine side effects of substance use disorder. And so one of my main interests include like adrenal insufficiency related to opioids, because I think it's a little bit different than other forms. And spoiler alert, we don't really know what to do there. So my goal today is to talk to you a little bit about adrenal insufficiency, my thoughts about it, what should sort of raise your flags and how to approach it. And then we'll also touch on more male hypogonadism than female. We'll talk about reasons for that later. And then everybody loves that high prolactin level that gets ordered. And we'll just talk a little bit about that in the context of some substances. And so this is the Strait of Georgia between British Columbia and Washington State. This is an estuary where the sort of salt water of the ocean meets the fresh water coming off the land. And oftentimes people say, oh, addiction medicine, endocrinology, those are pretty subdivided. How does one ever get involved with both? And really, if you know anything about geology or estuaries, while it looks divided at the surface, you have like multiple areas of hidden admixture here. And it's these areas where I like to hang out and think about things. And so, as I mentioned, we'll talk sort of about 3 different flavors of how opioids affect the hypothalamus and pituitary gland. I'm not going to say everything's going to be more clear after this talk, but at least, you know, we've all thought about this now once. Feel free to throw questions in the chat. I should be able to see them, or you could just unmute yourself and interrupt. I think if you put your hand up, it should sort of throw you at the top of my screen as well. But please, I'm not trying to take up the whole hour, but we'll see. I always say that and somehow end up stretching things. Anyway, we'll start just with a case to kind of frame our thinking. You see a 64-year-old man, he has chronic back pain, he has nausea, vomiting, he has fallen recently. As far as what he takes for medicines at home, he just takes ibuprofen, and then he's also on methadone, 110 milligrams daily. As far as like some pertinent initial lab workup, we don't get into too much. His sodium is 129. He gets a morning cortisol that's 3 micrograms per deciliter. Someone is really remembering their endocrinology and then decides to get a cocentropic stim test, and it stims to 12. And so what would we maybe do in this particular situation? So you may have guessed, we'll talk about adrenal insufficiency first. And I don't know about you, but I particularly love our different hormone axes. If you remember, you have your hypothalamus that secretes CRH or corticotropin releasing hormone. And then your pituitary in response secretes ACTH, which tells your adrenal gland to make cortisol. And cortisol does so many important things. There are other regulators in here too, but we won't get into that. Well, where do opioids interfere with the system? Definitely at the hypothalamus and to some degree in the anterior pituitary gland. There's also opioid receptors in your adrenal glands as well, but that's kind of complex and it's not clear how clinically relevant those are, so we won't particularly talk about it. But to sort of frame like the receptor density, if you look at where gene expression of the different major opioid receptors are, you can see that compared to like the anterior pituitary, most of these, in particular the mu receptor, they're concentrated in the hypothalamus. And so I think this is from one of the very early studies on sort of opioid type molecules and what happens to your ACTH and cortisol. What they did is they took beta endorphin, which does stimulate the mu opioid receptor, and they infused it. And then this sort of looks at your cortisol over time. And when they infused a controlled or like non-opioid substance, I should say, to be clear here, nothing really changed as far as the cortisol concentration over like 3.5 hours. But you can see significant decreases in cortisol from the beta endorphin infusion. When we look at what was going on with ACTH, we can also see that that fell over time. And just as a matter of interest, you can see that with the short-term opioid infusion, prolactin rose and then came back down, and there was no change in growth hormone. So we know that opioids interfere primarily with your HPA axis, your hypothalamic pituitary adrenal axis, primarily through decreasing ACTH secretion. There's probably activity at your mu kappa and delta receptors, but it's probably predominated by activity at the mu, and this all decreases cortisol secretion. In some other studies after that one, it's been seen that oral morphine attenuates your ACTH rise in response to administration of this corticotropin releasing hormone, or CRH, which would usually be a hypothalamic hormone, and that also decreases your cortisol. And then interestingly, when we give a full antagonist, naloxone, you don't see this same blunting effect. Rather, you see it almost like a hyper response to infusion of CRH, which is kind of interesting. So from a physiologic standpoint, obviously everybody's captivated. This is interesting, but is this at all clinically relevant? And there was a pretty decent meta-analysis done, except they didn't really define like the dosage of opioids here. And this wasn't folks with just substance use disorder. This was probably more people with chronic pain, but all you had to do to be included in one of these sort of studies in the meta-analysis was have sort of chronic opioid therapy. They reported the median use was about 1.5 years, but there was nothing on sort of the dosage that was pulled out of these, and probably consisted of 205 patients total. But the prevalence is probably around maybe 15%, defining adrenal insufficiency as low morning cortisol level, an abnormal cosyntropin stim test, or an insulin tolerance test. However, we kind of have an interesting situation when defining opioid-related adrenal insufficiency. First of all, I'm just going to throw this on your radar. It's not necessarily specific to opioids, but our cortisol assays are getting better. So some of these cutoffs are changing. The classic teaching was if you had a morning cortisol of 18 or higher, or if you gave somebody cosyntropin, which is the synthetic ACTH, if you got to 18, you were good. That was the definition of no adrenal insufficiency. But with some of these newer cortisol cutoffs, a normal either morning cortisol or cortisol response to ACTH or cosyntropin, it's probably closer to 12 to 15. Again, not necessarily pertinent for our discussion, but good for everybody to know that that is changing. Probably the bigger question that I'm posing is this cosyntropin stim test a good study specifically for opioid-related adrenal insufficiency? And if we remember, these opioids are interfering predominantly at the pituitary gland somewhat, but mostly at the hypothalamus, right? You're sort of attenuating the ability to release CRH and the ability of then these anterior pituitary cells to release ACTH. Adrenal glands take time to atrophy as well. So if all of a sudden you give people large doses of steroids, or for whatever reason, you're turning off total ACTH production in the pituitary, you probably need at least 2 weeks for these adrenal glands to atrophy a little bit and to sort of decrease their ability to produce cortisol in response to ACTH. But sometimes that process can take up to 3 months. And so if people have been on opioids for a shorter period of time, sometimes having a low morning cortisol, but a normal stim test isn't really that informative just because your adrenal glands may not have had time to atrophy. And if you think about having an opioid on board, so you're almost pressing the brake somewhere in the hypothalamus and in the pituitary, such that even under a stressful situation or some other signal that should raise your ACTH to raise cortisol, there's a brake there. And it's hard to tell if a cosyntropin test is going to be really a good, true physiologic test of can somebody increase cortisol to stress response. And so, there's not really a study that has looked at this, but one interesting study just looked at people in the hospital and how things are working as far as their HPA access, their response to some of these cosyntropin stim tests. And then they weren't necessarily on opioids, but they compared to folks who are outpatients on opioid therapy getting these tests done. And when they looked at just hospitalized people, it was pretty common to find that they had a low morning cortisol or a cortisol of less than 3. But an abnormal stim test. 64% of them were normal, so the remaining were abnormal. And then when they looked at just outpatient folks on opioids, they found that 14% of them who had been on opioids for at least a month had a low cortisol and a normal stim test. And what do we do with that group of people? It's pretty hard to say. Marlene, did you have a thought, comment, or question?
No, I didn't.
Okay, wonderful. Sorry, you popped up on my screen, but it's all good. And so, I had mentioned maybe this cosyntropin stim test isn't really a great way to diagnose opioid-induced adrenal insufficiency. If we looked at that same meta-analysis and just pulled out the folks receiving an insulin tolerance test, which is probably it's really the gold standard for adrenal insufficiency, although in clinical practice, pretty hard and pretty dangerous to administer. Really, the prevalence is probably closer to 24% or 25%, understanding that this is a fairly small group of people. This is about 97 patients of that initial subset of 200 and some. And so how should we diagnose this if this is sort of fraught with problems and inaccuracy? Well, our usual adrenal insufficiency workup, sort of regardless of etiology, recommends a morning cortisol and a morning ACTH. And then you would do a 250 microgram cosentropin stim test to diagnose. Again, we've already talked about whether it's some other form of secondary adrenal insufficiency, but specifically one in which opioids are blunting that ACTH release. It's less sensitive. And you can't really trust a negative result as much. So what's the answer here? Well, sometimes we can get this test called DHEA sulfate. And so this was derived, I think, from actually some of the folks down at Mayo. Irina Bankos is one of the adrenal specialists down there. And she spends a little more time thinking about this than your average endocrinologist. Really, your beginning workup for a possible opioid-induced adrenal insufficiency. First of all, you should be screening based on questions. That's always tough, and for multiple reasons. We'll see this with hypogonadism too. The symptoms of adrenal insufficiency overlap with side effects from any kind of opioid agonist therapy like buprenorphine or methadone. Pretty big overlap there. People just, existing with an opioid use disorder, there's a lot of overlap in those symptoms. So that's kind of a tough thing clinically to parse out. But initial workup should start with a morning cortisol done between 8 and 9 a.m., an ACTH, and then this DHEA sulfate level. If you remember, DHEA sulfate is an adrenal androgen, also released under the control of ACTH. And because its half-life is longer than cortisol or ACTH, I think its half-life is about 7 to 12 hours, if I recall. Kind of gives you a little bit better, longer snapshot of your adrenal function. And so if you find that these morning screening labs are all low, namely a cortisol less than 10, ACTH less than 10, and a DHEA sulfate less than 50, it's pretty likely that there's adrenal insufficiency. And you don't need to do any confirmatory testing, and I wouldn't even worry about a cosentropin stim test. Probably repeat this one additional time just to make sure things agree. Sometimes people get sneaky joint injections of steroids, which could also cause a similar picture. So 2 data points in time is generally preferable to 1. If you do this testing and you find that the cortisol is above 10, the ACTH is above 20, and your DHEA sulfate is above 50, then your adrenal function is probably okay. You probably don't need to be worrying about opioid-induced adrenal insufficiency. It's really, things get sticky in this middle area where maybe you have a morning cortisol of 7 and ACTH is low, but your DHEA is around 50. That's probably when you need to do confirmatory testing. Again, they say consider an insulin tolerance test, but honestly, the only place where I think that is done might be Mayo. And again, it's high risk. It's difficult. I don't know anyone who actually does this in clinical practice, but then maybe you get a cosentropin stim test. And it doesn't sort of clinch the diagnosis, or I wouldn't make my treatment decision based solely on this, but it can sort of maybe clue you in particular if it's abnormal. And so we'll go back to our case with our gentleman who's on methadone, these previous labs here. Well, we end up getting a DHEA sulfate that is less than 50. And even though this test on some assays might be stimming to something that's about normal, I would treat in this particular situation. Oh, looks like my graphics are going to repeat here. And how do you treat? Well, you can look this up. I think this is on UpToDate, or you can pull it up in the adrenal insufficiency guidelines. But generally speaking, you want to give hydrocortisone 15 to 25 milligrams per day in divided doses. Or you can give a dose equivalent of prednisone. Typically, it's 4 to 5 milligrams every morning. Importantly, because this is a central process, you are not also having an aldosterone or a mineralocorticoid deficiency, so you don't need to worry about fludrocortisone. Sometimes for women with maybe persistent fatigue or libido issues, you can consider DHEA supplementation, but it's not really the point of this talk. That is debatable. The important thing is if you suspect it, treat with hydrocortisone or prednisone. Even though we think that this is a thing, it's always interesting to see if there's data on people who do treatment of opioid-related adrenal insufficiency, and there really aren't very many studies out there. So one sort of review looked at these like 57 folks and the 2 studies in which they participated and tried to define endpoints to see if other things improved. And the first study, yes, it was a randomized sort of placebo-controlled trial, but they defined adrenal insufficiency as a cortisol in response to this cold pressor test, which isn't sort of a validated clinically used measure. Basically, what they did was they inflated a blood pressure cuff around somebody's arm in warm water. They then moved it to water that was at a freezing temperature, and then it was kept there until people couldn't tolerate the freezing cold pain, or I think it was like a maximum of 2 minutes. And then they threw cortisol levels at sort of 30, 60, 90, 120 minutes after that. So super, super weird, like as far as how they were defining opioid-induced adrenal insufficiency. They did say that folks who were treated had maybe improvement in their pain and like vitality on like this wellness battery, and maybe had some mood and activity improvement too. But again, not a great study, not a validated test. It was also over a short period of time. This other retrospective study looked at folks who had been on maybe like 105 morphine equivalent milligrams per day for a median of 96 months. And they had better sort of inclusion criteria or diagnosis of opioid-induced adrenal insufficiency, and maybe reported some improvements in things like musculoskeletal pain, fatigue, and weight gain. But again, very limited data, probably not enough. And it certainly wasn't a randomized trial to say for sure that, oh, for these people with opioid-induced adrenal insufficiency, does treatment help their overall like well-being? And in particular, does it improve their treatment with opioids? These folks were not folks with an opioid use disorder too. These are just folks who are on like chronic opioid therapy. All right, so this is just a summary. We don't have formal guidelines for screening or diagnosing people. It's probably best just to check in with patients about possible symptoms of adrenal insufficiency. You know, very common things like fatigue, weight loss, muscle weakness, things like that. It is thought that people's risk increases when their morphine equivalent rises above a mere like 20 milligrams per day, but it can really be seen at any consistent opioid dose. And then again, our main tests that we're going to reach for: morning cortisol, ACTH, and DHEA sulfate. We know Cosentropin stim test is problematic, so we won't do that unless there are questions in this situation. And we talked about treatment as far as what you would do daily, but probably what's more important for these folks is if they're going in for a surgery or they're significantly ill and requiring hospitalization, we should probably have a much lower threshold to give them stress doses of steroid.
Ethan, can I ask a question?
I'm going to move on. Yes, please.
So is there ever the option, if you have somebody on a full agonist, to go to a buprenorphine? Does that make a difference?
That is a great question. The conventional thinking is yes, that by partial agonism and you get some partial antagonism, that you're not having such maybe a heavy foot or a heavy brake like on your CRH and ACTH. We'll talk a little bit about that in the context of hypogonadism, but there are no studies that I'm aware of to show that that clinically makes a difference for adrenal insufficiency. But that is something I'm interested in at least in terms of people maybe on methadone accumulating different hypothalamic maladies, like let's say they're hypoadrenal and hypogonad. Could you maybe then use that as another reason to switch them to buprenorphine for those to go away? And in theory, I think it would work. But again, I have no data to suggest that their adrenal recovery is better. But that's a great question. Perfect segue into talking about opioids and hypogonadism. And I'll admit, and I apologize, this is going to focus mostly on men. The data that exists for men on chronic opioids and hypogonadism, some exists. It's not great, but there's very, very little data out there that look at women and chronic opioid therapy. And unfortunately, the data that does exist for men and women, it predominantly looks at folks who are being treated for chronic pain and not on people who are receiving opioid agonist therapy for substance use disorder. So again, we'll just kind of frame our thinking here in another case, and we'll talk specifically about a 38-year-old man. He has an opioid use disorder. He's on buprenorphine, and he's just coming in for follow-up. But he tells his provider he's pretty fatigued, having low energy, virtually no erections, including random morning erections, and his libido's pretty low. He's noticed over the past 6 months he's gained about 25 pounds, but fortunately, he found this online men's health clinic, and he was just prescribed testosterone supinate 200 milligrams every week, although he hasn't started that. Yikes. As far as our hypothalamic pituitary gonadal axis, again, you have your hypothalamus. It's releasing this GnRH. This GnRH in turn is stimulating these gonadotroph cells to make LH and FSH. These reach your sort of end target sex organs, the testicles and the ovaries, and tell them to make testosterone and estradiol, respectively. We'll talk a little bit too. There's some activity over here in dopamine and the prolactin axis, but hold your horses. We'll talk about that a little bit later. Where do opioids sort of interfere here? Well, again, predominantly they're acting in the hypothalamus and decreasing this GnRH. When you look, I think this is done in rodents, I think mice, but they looked for sort of opioid suppression of mRNA for GnRH, and it was much lower in the animals that were receiving opioids. And so this is probably the main site of suppression. But there's also probably some pituitary suppression of FSH and LH outside of just the lower GnRH release, interestingly. And we talked a little bit before about mu and kappa receptors being involved. This is not that important unless you're a huge nerd, but these epsilon opioid receptors also exist, and there's probably some effects mediated through them, but it's predominantly mu. And so let's just take a quick second to talk about opioid-related sexual dysfunction, because I think it's really easy to think, okay, opioids on board, low GnRH, low testosterone, or low estradiol, right? And that's sort of the only story to this sexual dysfunction. But interestingly, there's probably more to it as well. You're probably having sexual changes independent of what a person's estradiol or testosterone level would be. As far as the incidence of this, it's really variable depending on the study. Could be as low as almost 30%, could be as high as 86%. In sort of a meta-analysis of quote unquote chronic opioid users. So again, not folks with opioid use disorder, but people who are just on some kind of opioid therapy all the time. It was present in 63% of folks. They weeded out a couple studies that they felt were maybe higher risk of bias, and this number rose to 69%, which is pretty significant. And while it's generally thought that either a morphine equivalent dose of 120 or higher, or some other study showed maybe methadone dose of 30 milligrams daily, which would be just a bit higher than this, that's really when the risk increases. But you can really have suppression of these sex hormones at any dose of opioid. What things are thought to increase risk? Well, a larger dose. If it's longer acting or sort of maintaining a more consistent serum level throughout the day, that probably increases risk of opioid-related hypogonadism. And also, if you have a higher mu affinity molecule, something like hydromorphone, for example, that also increases your risk. And again, just to emphasize this point that I made when we got to this slide, there are other sexual effects that are occurring other than strict hypogonadism relating to sexual dysfunction. And so this was that study. Just want to point out that 99.5% of the folks included in this meta-analysis were men, unfortunately. And again, that mean was about 63%. Thought that there is sort of this linear increase with dose, but really the pattern isn't that linear. Your risk of developing hypogonadism probably levels off. The caveat here being, though, there just weren't that many people included with a high morphine equivalent dose. And if you actually looked at folks, I think on reasonable doses of methadone for opioid use disorder, then you would be able to populate this part of the graph much more. Maybe it would change the dose dependent relationship that we see. I just like to throw this in here. We won't talk about this in super depth, but this just shows the different sort of affinities for the various opioid therapies that we have. See morphine, fentanyl, like oxy, fairly high. Other ones are low. There are different affinities at other receptors, but that is not really relevant to our discussion. So I'm going to get to this point here. If you look at a couple of different sources, and I think there might even be some reference to this in one of the endocrine guidelines, they say that buprenorphine has a lower rate of hypogonadism than methadone. Intuitively, this makes sense, right? Especially if we're talking about time sort of spent on like the mu receptor, and you think partial agonist, partial antagonist, we're going to decrease our risk of side effects. But let's look at what the data says. I think there's probably two different studies. This one looked at about 126 men, and they were actually on buprenorphine or methadone. And if we look, the folks on buprenorphine had higher sort of sexual desire scores, and this was significant. And then if we look at their total testosterone levels, sorry, I should have put the equivalent. This is like the European sort of unit. This isn't like our standard system where like a normal testosterone is probably about like 200. But the point being that the folks on buprenorphine had higher testosterone levels as well. So case closed, right? Buprenorphine is better. Well, if we look at the actual dose used in this study, they were on 75 or almost 75 milligrams of methadone versus like 2.5 milligrams of buprenorphine, which is a huge difference. And obviously we know that, you know, the conversion for like a buprenorphine dose to like a morphine equivalency, like that is not like a standard thing that we can always predict. But we definitely know that 75 of methadone is much more than 2.5 of buprenorphine. Okay, let's see if the next study is any better to back up that claim. This one was smaller, but it looked at 54 folks or 54 men on treatment for opioid use disorder. And again, they found that with methadone, testosterone levels were lower, almost twice as low, in fact. And they found if they would look at the doses, however, these folks were on 88 milligrams of methadone. And while these folks were on higher doses of buprenorphine, like 11 or 12, that's still a pretty big dose discrepancy. And so when it comes to this question of which is going to have the lower risk of hypogonadism, yes, the studies we have show that testosterone tends to be lower and the incidence of hypogonadism higher with methadone. But in both of these studies, the cohorts who are on methadone were on like higher doses. So I don't think that we can yet parse it out from just like a dose related effect. And I don't know like how many of you deal with methadone consistently versus deal with buprenorphine. I gave some version of this talk somewhere where, you know, what somebody asked me what is considered like a high dose of buprenorphine. Or like a Suboxone product in particular. And, you know, my thought is if like a high dose of buprenorphine is usually 24 milligrams, that's the max. In Colorado, we can sometimes get Medicaid to give like 32 milligrams per day. And it's probably thought that you're really getting, you know, almost 100% receptor saturation on that. Although in the era of fentanyl, maybe that data comes out a little bit differently. But when I see people on methadone of more than like 100 or maybe even more than 120 per day, that's when I start becoming concerned that even if I switch someone to Suboxone, I'm not sure if 24 or 32 milligrams a day will give them the same craving relief or withdrawal prevention as the methadone. So I kind of put, about methadone 100 to 120, functionally around like buprenorphine, like 24 or 32. And so again, even though like a buprenorphine dose of 11 might seem high, that's still less than half of what I consider like a full dose of buprenorphine, as opposed to methadone of like 88 or 90, which I would consider considerably higher. So this exists, great, right? Like how are we recommended to screen for this? Should we be checking testosterone or estradiol levels on everybody? Well, as we know, as far as the general population is concerned, we don't routinely screen with labs or even ask people symptoms. We generally wait until people come to our office with some kind of concern. And the same is recommended in cases of like opioid-related hypogonadism. We should be testing only when signs or symptoms are present. The Endo Society has some hypogonadism guidelines that haven't been updated in a while. I think these are probably like, I can't remember if it was 2014 or 2015, maybe 2017. But all they say about opioids are that, you know, providers should consider replacing testosterone in men with opioid-induced hypogonadism as long as they're experiencing sexual symptoms and in cases where they are unlikely to discontinue opioid medication. And I think that that is kind of funny. We'll talk about that in a little bit. But when do you start it? What dose do you do and how frequently? There's not really like good guidance on this for hypogonadism specifically. So some folks have devised this algorithm, and I think this is probably where we start. If someone has been using buprenorphine, methadone, or really any chronic opioid for at least 6 months, we should probably ask them about signs and symptoms of opioid-induced hypogonadism. If they report some of these symptoms in men getting a morning testosterone, but also some of these pituitary hormones, prolactin, LH, and FSH are important. Sort of a low morning testosterone, you always want to confirm with sort of a second test. You can't really, for insurance purposes and probably clinically, it makes sense to just sort of use one morning reading as your basis for prescription of testosterone. If you check these things and they're normal, well, you should just check in with your patient another 6 months, ask them if symptoms are changing, and then consider testing if things do change. In women, it's pretty similar. You should be checking E2 as estradiol. So you should check an estradiol in addition to the LH, FSH, and prolactin. And then if these things are low, consider hormone replacement therapy. And if things are normal and they're still having signs and symptoms, you should make sure they're getting good follow-up with their OBGYN. Women present a little bit more of an interesting case, right? Because even though there's maybe some like cyclical nature over the course of the day to these things for men, and maybe there are other cycles too that we know less about, women are on sort of, generally speaking, like a monthly fluctuation in these hormone levels. So then the question becomes, oh, when should we test? Is there a better point in the menstrual cycle to test? And the short answer is yes, probably like 5 days after their initial menstrual period. But as we know, not everybody has regular cycles. When people are on opioids and having these symptoms, they might have amenorrhea or oligomenorrhea. So how do you time out these labs? And I think you can really check them anytime, because I think what's going to be most characteristic or telling, if you see a lowish estradiol, but then a low LH and a low FSH, I think these can clue you in pretty significantly to some opioid hypothalamic suppression. And then if you end up checking again, like a second point in time, sort of regardless or irrespective of when their next period is going to be, and they're also low, then I think you can feel pretty good that they're hypogonadal, and you should think about hormone replacement therapy. I alluded to this earlier. The major problem with this screening strategy is, where do the hypogonad symptoms start, and like the symptoms of everything else going in life end.
I'm making
We know that,
lunch, which it is now available.
Sorry, what was that? Could you repeat that?
I think she didn't mean to unmute.
Okay, that's okay. Yeah, as we know, there are side effects from the medicines we use to treat opioid use disorder. There are side effects too, just from having an opioid use disorder or like going through withdrawal. So it makes this pretty difficult. I wish I could sit here and say, okay, here are like the highest sort of sensitivity, specificity symptoms that you can ask your person to see if they have hypogonadism. And I really can't, because there's other sexual dysfunction that occurs with these things too. I think, you know, erections are probably an overblown symptom and happen from so many other reasons. It's really probably more like libido is probably like your moneymaker question there. But even then, that's a tough thing to assess. The other thing that complicates this picture too are the other comorbidities that lead to this central or the secondary or hypogonadotrophic hypogonadism, meaning sort of hypogonadism that arises from like the hypothalamus and pituitary. Like how many people do we see have undiagnosed sleep apnea? Probably a lot, at least in my practice. And it's really suggested that you correct this before throwing testosterone at people. But anytime people have significant BMI elevation, folks who have gone through like recurrent head trauma or like a bad TBI, cannabis use, high prolactin levels, which we'll talk about in a little bit. If people, again, are going through other stuff, chronic pain, getting glucocorticoid injections in various joints, this can turn off your sort of hypothalamic pituitary gonad process. And then too, in particular in men, I always screen folks for hemochromatosis if they have low testosterone and not one of these other causes. A non-insignificant portion of folks develop pituitary tumors. People who are experiencing like life chaos and homelessness, if the energy expenditure isn't matching the energy that they take in, that also leads to hypogonadism. And then when people have pretty significant uncontrolled chronic comorbidities or like a more acute illness, all of these things lead to your body kind of turning off that FSH, LH to testosterone estradiol axis. And so when we do test, which we do, I alluded to this earlier, it's generally recommended that 2 morning fasting total testosterone levels are checked. People wonder, why does it matter if it's fasting or not? And there was a study done that shows if you eat a meal, your testosterone level can change or go down afterwards, probably maybe up to 25%, which is why we recommend that it's done fasting in the morning. I've had other folks ask me too, okay, well, cool, I have my total testosterone. When should I get like a free or bioavailable testosterone? And really, if this total testosterone is kind of like borderline or doesn't make a lot of sense, it's never wrong to check a free level or a sex hormone binding globulin level, which most of your testosterone rides around on this, probably about 40 to 60%. This doesn't really have much to do with our discussion, but again, as an endocrinologist, talking to folks who might not be able to talk to endocrinologists super often, what's the difference between free and bioavailable testosterone? Well, free testosterone measures just the totally unbound portion. Your testosterone, in addition to being bound to this sex hormone binding globulin, also binds loosely to albumin. If I remember correctly, it's probably 40 to 60% bound to this. You probably have maybe another 30 to 40 that binds to your albumin. And then the remaining 10% or so is free. Because it's so loosely bound to albumin, that testosterone is considered biologically active. And so these bioavailable assays, they'll typically tell you like the combination sum of the free plus the albumin bound testosterone. So that's today's irrelevant fun fact for you. What else are we considering when we're testing for hypogonadism? Well, already mentioned, check those other pituitary hormones, FSH and LH. Also want to check the prolactin. And then in particular, in men for hemochromatosis, I'll usually check a ferritin and an iron saturation level. The hypogonadism guidelines for men from the Endo Society recommend that a total level less than 150, you should be checking like a pituitary hormone panel, checking those other things, because it's generally here where we start to see things like compressive pituitary tumors and things like that. Probably good to pull the trigger on an MRI pituitary as well. This is with the conventional assays. And so things are a little different now. I've seen maybe 1 or 2 total testosterone assays where they're considering like an upper limit, or excuse me, a lower limit of normal around like 120. So if that's your lower limit cutoff for your assay, then I would think of, if normal is considered 200 here, this is about 75% of that lower limit. I'd take that same percentage and apply it to whatever your lab's sort of lower limit assay for men would be. So if it's 120, it's got to be about like 90 or so. So This is a general number, but usually if it's less than like 75% of that lower limit of normal, look at the pituitary glands. When you're talking to people too, not a bad idea to screen for comorbidities. That we saw that big long list. So if people are having vision changes or headaches, regardless of how low the testosterone is, maybe it's like slightly low, it's reasonable to order a pituitary MRI. If folks are having issues with daytime sleepiness or some kind of sleep disturbance, probably a good idea to screen them for sleep apnea with a sleep study. And then if people have just been in the hospital, they're acutely sick, or they have like super uncontrolled diabetes or something, do your best to get that under control and retest if you can. What do the guidelines say? Or sometimes when I am doing questions for endocrine board exams, how can you treat this? A lot of the questions will have the answer of stop opioids, which is kind of ridiculous because most of the time that's not really feasible, in particular in a primary care endocrine office where you're seeing someone for low, like testosterone. Interestingly, if people can get off of opioids, though, their access return or the return of their sort of gonad function can occur in as little as 1 month. And this was shown in a study of folks who are predominantly using heroin back in the good old days. What other things can you do? Well, we think it's dose dependent. So if you can reduce their opioid dose, great. Switch to buprenorphine. We did talk about that a little bit. Maybe it helps, but we really haven't looked and compared folks at sort of high dose buprenorphine to folks on methadone. But really, at the end of the day, you can always start testosterone replacement. But I don't really want to go into specifics. I think Katie has these slides available for you all. I think I might have taken this directly from Up to Date, but these are sort of the different starting doses you can use for testosterone. There are different sort of monitoring criteria for like the different forms. Generally for injections, you can check a midpoint level and you want it to be between 350 and 600. Some people will also check a trough level, like right before their next injection. And as long as it's right around that lower limit of normal, you're okay. If it's higher than that, you want to decrease the dose. There are different sort of recommendations for like gel, patch, and there are testosterone pills and things too. And we'll talk a little bit about, is there a preferred form in a little bit. But why treat this? Why can't we just let people be? Well, we think it probably helps with libido and sexual dysfunction. We think that testosterone or estradiol can improve mood and well-being, and then eventually reduce the risk of osteoporosis and fracture. There's one study done through the VA that made some pretty bold claims. They said they looked at folks who were started on testosterone by their clinician, and then they just looked at outcomes. These folks specifically were on some kind of opioid therapy. It's not clear what the doses were, but if they had a testosterone of less than 300, then they were pulled into this analysis, and then they were propensity matched with folks on opioids and low testosterones who were not treated. And what they said was there was a significant mortality benefit. If you looked at the folks on testosterone, they had like a lower hazard ratio than the folks who weren't treated. They looked specifically at major sort of cardiac endpoints, showed the same thing. And then when they looked at fractures, the folks treated with testosterone seemed to have drastically fewer fractures too. That seems pretty good. That probably means we should treat everyone with testosterone, right? These are just those Kaplan-Meier curves that showed that survival benefit. The problem here was this was completely observational. The patients were selected for testosterone therapy by their clinicians, and they didn't look at some of the other outcomes like sexual function. And when it comes to deciding who gets testosterone, at least in the folks that I like trained with, generally people are healthy, well, without other comorbidities. So this is a highly, highly biased study. So if someone says that opioids plus low testosterone plus testosterone replacement equals survival benefit, you got to give a big like hold up there because this study was not the greatest. What about some better studies? Well, pretty variable, actually. When they looked at folks who received testosterone or this testosterone replacement therapy, one showed that maybe some folks had better sort of emotional well-being and better pain scores, but didn't have any change on other mood scores like depression or quality of life or sexual functioning. But a different study did show improvement in sexual function. Yet another study showed that maybe folks needed less opioids for pain when they added testosterone. But then a number of other studies showed that that relationship was not maintained, which is really too bad. So we really have inconsistent data. So then it comes down to the question again, do we really treat opioid-induced hypogonadism if the outcomes aren't necessarily clear? And my thought is probably yes. I mean, we treat folks with hypogonadism with testosterone, even though if you look at a Cochrane review of who gets testosterone for hypogonadism of any reason, the improvement in sexual health really isn't as great as we once thought. There's probably a significant placebo effect to it, and that's a whole story we could talk about later. And then one thing I think that's reassuring is that treatment with testosterone, the risk there is probably less extreme than we previously thought, at least in terms of cardiovascular health, sort of prostate problems down the road. But the huge caveat here is as long as the levels are kept physiologic. There was that recent New England Journal study where they gave men testosterone therapy, kept their levels 400 to 700, and they really didn't have higher adverse outcomes than the folks treated with testosterone, except that they had more fractures, and I'm still not exactly sure why that happened. So then what testosterone formulation? There's no data on this. I've had people ask me questions before. Okay, if I'm giving somebody IM or sub-Q testosterone, which can be done, is that going to cause problems in folks who have used needles to inject other substances? And I don't necessarily know of any studies that say that it will, but I do think that my first choice is testosterone gel, predominantly from the fact that you can keep their levels like much more stable. Injections are fine. I find a lot of men asking me for testosterone want to use injections. I think because they think that they'll get better results. And really, some injection regimens, you do get fairly high peaks and troughs. And it's around those peaks where people have increased, risk of side effects, in particular, like polycythemia. So I'm not against using injection testosterone for folks, but I really try to get them to do like a daily gel first. Patches theoretically are great, but I have a lot of folks who are concerned about skin irritation with that. Pills exist now. They work fairly well. It's just difficult to get covered by insurance, and there's virtually no like public insurance or Medicaid program that I'm aware of that can get people this. A lot of people do pellets. I never do pellets because I only see the problems with them. What problems do I see? Just super physiologic high testosterone levels for long periods of time. Again, if you do this or you work with your urologist who does this and they do it in a way that keeps the levels stable, fine, go ahead. I don't care. But I would have a hard time telling anybody to go get testosterone pellets based on what I see. All right. What about the other half of the population that can have hypogonadism from opioids? There are so few studies about this. It's pretty unfortunate. And they tend to be more observational as well. As we've assessed before, because there's a cyclical nature to these gonadal hormones, it's much more difficult to assess function and understand what those numbers tell us. So in one study, they looked at folks on chronic opioids for pain, and probably 20 to 50% of them were experiencing oligomenorrhea or complete amenorrhea. In another study that looked at levels, probably around 50% saw lower estradiol, testosterone, and DHEA sulfate levels in women who were on any kind of opioid. Some of these studies showed low libido, not surprising, symptomatic. Hot flashes occurred in more folks too. So we should just replace, right? Well, unfortunately, estradiol replacement becomes a little more complicated in women because we do know that folks who are older than 35 to 40 and who also use tobacco increase their risk of a thromboembolic event like a DVT or a PE. So what do we do in that situation? Well, Generally speaking, transdermal estradiol or estrogen patches are preferable. The rates of VT are lower in other populations who are put on this form. And then maybe we have to shift to lower doses of estradiol. There's some thought in some studies that the type of estradiol or progesterone in a combined oral contraceptive pills will be less thrombogenic. But the jury really is out on this, and there's virtually no data to look at, what happens when we do replace specifically in opioid-related hypogonadism for women, what their outcomes are like, which is too bad. But maybe somebody should do something about that someday. All right, circling back to our case, our 38-year-old, he's fatigued, gained weight, having significant sexual dysfunction symptoms. On further history, he has uncontrolled diabetes diagnosed 9 months ago. He has sleep apnea. His BMI is elevated. He gets Sublocade every month, and this will be his next dose will be his 10th. He just started some medications for his diabetes. He's also on Abilify 5 milligrams daily. As far as like other things that can contribute to sexual dysfunction, he now has like a new romantic partner, and he uses cannabis concentrates. You also find he's had headaches, maybe some visual acuity change, but he has to turn his neck farther when driving, which may indicate a peripheral vision deficit. There's a whole bunch of reasons why this guy could have hypogonadism besides just the Sublocade. So levels were done. He does have like a low morning testosterone of 120 or of 170, which is low but not crazy. Some lower but not completely suppressed FSH, LH, prolactin only slightly high. You can see some of his like metabolic markers here too. Thyroid function was fine. With the headaches and visual field changes, his provider was concerned visual field testing was normal. MRI pituitary was normal. A second testosterone was 164. He has severe sleep apnea. So the recommendations before initiating testosterone therapy for this person were to get stable on a CPAP, recheck testosterone after that, get these blood sugars under control, and start a statin and follow up later. All right. I'm running up against the clock. Sorry about that. What's the deal with prolactin? This would be pretty easy. We saw this picture once before, and as you can see, it's thought that these sort of, chronic opioids will deplete dopamine in the hypothalamus. And if you remember how your lactotroph or your prolactin producing cells work, you need dopamine around to suppress the prolactin. Dopamine is like the brake. So when dopamine is low, or if people are on certain medications that block dopamine effect, think mainly antipsychotics, then prolactin rises. It's not just opioids that can affect your dopamine access, either acutely or chronically, but maybe other things that deplete your dopamine over time. Think like cocaine or methamphetamine. You can also see elevated prolactin levels in those situations as well. But also probably another major source of high prolactin are various medications for mental health. Really, the antipsychotics are the big ones, but any of like the antidepressants can also do it. There are a couple other medicines too, maybe that we would worry about less. All right. So our major points, we already reviewed opioid-induced adrenal insufficiency. Big takeaway here is get that DHEA sulfate level. And if it's less than 50, along with low levels of these other hormones, boom, slam dunk, you probably have adrenal insufficiency. They should be on daily steroids and stress dosing when in the hospital or receiving surgery. And when it comes to hypogonadism, every 6 months, check in, ask about symptoms of hypogonadism, like libido, things like that. They're present for both men and women. Don't just get the morning testosterone or estradiol, also get FSH, LH, and prolactin. And that is all that I have. So if folks have any questions, happy to reach out. Otherwise, yeah, these slides I think will be made available at some point.
Well, I have questions. Anybody else want to jump in with any questions? One of the things that it's interesting because a lot of the family doctors here in St. Cloud do not do testosterone injections in their office, which I can tell you rurally everybody kind of does. So all of ours go to the urologist. Well, often we'll see people who've been on opioids for a long time. They have low testosterone, and they also had an opioid use disorder. They end up on Suboxone, but they have all of these things you've talked about, and they're smoking weed. And so when they go to the, and you're in Colorado, so everybody's smoking weed. So you go
Yeah.
you go to urology, and they say, well, we're not going to replace your testosterone because you're smoking marijuana. You got to stop that. So they're not going to stop that, right? So would you say
Yeah.
you need treatment? I mean, you're gonna have to treat them, correct?
Yeah. I guess I don't really care that much about weed. And it's maybe a little unfair for some of these other causes of hypogonadism, what I like pick and choose. But if they're using marijuana, and if they think that marijuana is helping with like other things in their recovery, or it's like, yes, I no longer take oxycodone or smoke fentanyl pills or this and that, but I have my marijuana and my Suboxone. I'm not trying to rock that boat. I think the discussion becomes a little bit different when it's like uncontrolled diabetes or sleep apnea, because there's so many other downstream effects of like that sleep apnea. I really want to try to get people in, as long as they have like stable house, like a place to use their CPAP. Like, and almost, I don't know, ethically speaking, I don't like to hold things over people's head. Like, I'm not going to give you testosterone until you get a CPAP and start using. But I think I make it more of a, let's see how the CPAP works with the testosterone. This is super common. It's better for your health. I'm usually pretty reluctant to start testosterone before things like optimizing sleep apnea. That's not to say I haven't done it. That's not to say that there haven't been cases where, it's difficult to see sleep medicine and people are like pretty hypogonad, and I'll say, okay, we'll do some gel. You'll get on CPAP and we'll just kind of reassess as we go along. Like, I have certainly done that. And I think, again, for me, the most reassuring thing, not that I'm pretty conservative with my testosterone. I don't just give it out like a lot of these sort of like men's health clinics. But especially if it's gel, if it's monitored, if people are staying within that zone, I'm probably not doing that much harm.
Yeah, it's interesting too. I mean, I think that I'm kind of the same way. It's like I send them to urology, and they don't want to. They won't start them on testosterone, but they're not going to stop weed, and they need this testosterone. And whether you believe the VA study or not, that kind of shows, improved all-cause mortality on testosterone. I guess I feel like, yeah, I can't hold that over their head. They're going to smoke the weed. You still got to replace them. One of the things I always think about is the bounce back effect, like with that testosterone. And so often, like, and literally so many people have all these problems coming in. They've been using fentanyl for a while, and you start them on buprenorphine, you wait a month or two, they got all these other things, and you're getting the sleep studies and the testosterones. Do you ever recheck their testosterone a year down the road, 6 months down the road on bupe, just to see if it recovers on bupe? Because there are some studies showing, again, 40%, 50% of people on bupe still have low testosterone.
Would I do that? Yes, but because the panel of patients I see now is like as an addiction specialist has only started like in the past year, and I maybe have like 2 or 3 people on testosterone, and they're getting it from like another source, and I'm here trying to persuade them to like put down the needles and the vials that they're getting from like the men's wellness clinic from Florida and onto gel. Like, that has been like a tough sell. But yeah, so it's sort of in the next step, when I'm out of fellowship and have some of these folks that I'm following over a long period of time, for my own curiosity's sake, yes, I will be checking 6-12 months down the road, especially if it is a situation where they were on methadone, they went to Suboxone, or if they were on any kind of non-prescribed opioid and they went to buprenorphine. Yeah, those trends are super interesting to me. I think, too, in an ideal world, I have some contacts at some of the methadone clinics here in town, and it would just be really interesting to grab a hormone snapshot at that point in time. And then when folks either reemerge, or our methadone clinics are pretty good at switching people to buprenorphine if they want, like checking that again, I think that'd be a really interesting trend to watch.
All right, being cognizant of time, are there any other questions before we let Ethan go? All right, Aaron?
Thank you so much for presenting today.
Yeah, thanks for having me. It's nice to join you all.
Yeah, well, thanks again. Really appreciate your time. Hope everybody starts checking those testosterons and kind of looking at all these things that you've spoken about, because it is important. So thanks again, and enjoy Colorado.
Yeah, definitely a little milder at times, but thank you. Really appreciate it.
All right, take care, everybody. See everybody next week. And if there's any questions, please reach out to Katie. Have a good day, everyone.